And in the hot seat this morning is no stranger to the hot seat. Peterson Wachira is the national chairman of the Kenya Union of Clinical Officers, fondly known by a lot of us as KUKO. Peterson, good morning.
Good morning.
How are you?
I'm quite well. Missed being here, but I've been listening, of course. I've been here virtually.
Yes.
Where great conversations do happen.
Yeah.
And we really enjoy the free civic lessons as Kenyans.
Well, asante sana, and it's good to have you here.
Thank you.
Looking into, and I think, the other day I was in a meeting and to deal with something that was quite major. And the head of the meeting said, you know what, I don't want to see you in my office again. And she was not saying it in a bad way. And I understood what she was saying. She was saying, I don't want us to be in a situation like this again, where we are going to have to call a meeting like this for us to sit down and sort out these matters. It's like a doctor saying, I don't want to see you again. I don't want you to be sick. So, Peter, we don't want to have a discussion like this every time where we are dealing with the plight of clinical officers. That we've had this conversation so many times that we don't want to have it anymore. But you know what? We need to have it because we are getting to the point whereby year on year, very little is changing. So that forms the basis of the conversation that we'll have this morning. But before we do, I happen to know that you like fufu and egusi soup. But there's some other people and across the way who also make it, they try to imitate it. And they're from a land that Mark will tell you a proverb from, and we would like you to interpret that for us.
You know what she's really not saying is that they have a competition ongoing with where she comes from about who makes the best jollof rice.
Hands down. It's not even a competition. How do you compete with something that is not even the same stratosphere as you? You can't.
As you can see, it is. And then they also
the competition is real.
Yes, it is real. And then they also happen to have two things that you'll be amazed to know. Blood oranges. Do you know what those are?
Blood oranges.
Yes, it's a very interesting orange that
the flesh is red.
The flesh is red.
Red.
It's
delicious.
It is very delicious. Okay. And then they have snails, big snails, big like a sufuria. Right?
Okay, not that big, but okay.
Being hooked on the street.
They're like this big, and they're eaten with fufu.
They eat them.
Yes.
Okay.
Yes. So this land is called Ghana. Yes, it is the opposite of Ndu. So, so you see, jollof rice was and things like that, opposite of you.
Ghana.
I beg Joe, give Peterson the proverb.
That's not what you cannot do. Tear you away from what you can do. Let not what you cannot do tear you away from what you can do.
Yeah. I think what that means is that don't focus too much on the negatives. Focus on the positives. Look at your capacity and know what your capacity is, what you can be able to do, so that then you can be able to define your course. Because if you focus on the negatives or what you cannot be able to do or change, then you might never move. And even mentally, you'll be affected because you might define yourself as a failure, where actually you're just focusing on where you shouldn't.
Yep.
So it's great because the focus that you give to something essentially gives it more life.
Then maybe with that I can probably ask the musicians from where I come from, please focus on what you can do. You may not be able to change some of the perception from the people.
Yeah.
Focus on your music.
You can sing, Abby. You can sing, then sing.
Yeah, because I've seen some of them, they're almost falling into depression. And I think it's a serious thing. And I think if we have those volunteers who are counselors, it is good to engage these people.
Mount Kenya musicians are depressed because of Rigiji.
Look, I agree with you because the thing that you can do as a musician, we call you a musician because you can do certain things. You can sing, my friend, sing.
Yes.
Focus on that one. These are the things that you're trying to don't.
Yes.
Focus on the thing that you can actually do.
You can actually sing about the depression. Yes. Or how you're being treated.
Yeah.
Put it in the music.
Yes.
And let it carry the day. And so we then move that to what we can do about this state that we are currently in. UHC, otherwise known as Universal Health Coverage, not care, Universal Health Coverage was introduced into the country around the time that we started to hear about the Big Four agenda, and this was under President Uhuru Kenyatta's administration. It was piloted in 4 counties, and then after that, though we're still waiting for the report of that pilot, we then were told that this was going to happen. We were going to make it, and then it went on to become what we know today as Taifa Care. Essentially what it meant is that the coverage of health services around the country was going to ensure that Kenyans would be able to walk into a health facility at whatever level after maybe being referred, or if you needed to go in for first point care, that you would be able to do that because of your contribution. You would walk out then having been treated and sorted out without having to add a coin. That was the general idea. We focus on that a lot. What we don't focus on more often is what happens to the people who are administering this care. The workers, the nurses, the doctors, the clinical officers, your equipment managers, radiologists and such. What happens to them? And what kind of care were they guaranteed as they practice the business of medicine? Now, we have many a CBA in place. Nurses have a CBA, doctors have a CBA, clinical officers have a CBA, running between the years 2017 and 2024. There's another one now that's currently in 2025. It goes on and on. CBA, effectively, what it's meant to do is to ensure that the working conditions for these people are actually kept, paid for, honored. You were in this seat some months ago, telling us, Peterson, that CBA has not been honored and that universal health coverage is actually not being practiced or absorbed. Is that still the case today?
Thank you, Ndu. And I really like how you put it and contextualize it. And please allow me to lay some background before I answer that, so that Kenyans understand where we are coming from. During the late Excellency President Mwai Kibaki's time, he gave us a vision. And we as a country gave ourselves a vision. In that vision, there is a pillar on healthcare. That vision should be achieved by the year 2030. On the side of the healthcare, we want to become a medical tourism destination in Africa. And then it breaks it down. How do we get there? We are going to have specialized and subspecialized hospitals. But how do you also get those specialized and subspecialized hospitals? You are going to have specialized and subspecialized health workers. But before you even get there, you must have an adequate number in terms of staffing so that you have enough to see the patients. And you can send the others back to school to be able to specialize and subspecialize. The other authority we must refer to is the World Health Organization. And during one of the World Health Assemblies, like the one that we had last week, there was an agreement that we should have universal health access, which was broken down into 3 things. Access to everybody, closest to where they are. Quality of health service that they're able to access. And when they access that quality health care, it should be affordable enough so that they do not suffer catastrophic financial challenges that will lead to poverty. Both of these are supposed to be achieved in the year 2030. We should be at a point where we say that now we have achieved the basics. We are now running the system. So then, what has Kenya done? In 2014, CS Macharia, representing the government of Kenya, attended the WHO Human Resource for Health Conference in Brazil. And he actually signed a commitment that because we recognize the shortage that we do have of the healthcare workers and how it is going to hinder achievement of UHC because there is no access without a health worker, Kenya will be employing 12,000 healthcare workers annually.
Okay.
Those are not my words. That is Kenya's commitment signed by the CS in charge of health in Brazil. Then that didn't happen. We devolved. That was in 2013, actually, not 2014. Immediately he came back, we devolved, and we all know the story. The employment has not been up to par. So when President Uhuru Kenyatta, the fourth president, came in and now wanted to actualize the universal health coverage, they realized that we didn't have adequate staffing. And what did he do?
Yeah.
He turned to the counties, but the counties did not have the capacity, the financial capacity to employ them. In the spirit of capacity building, which is also in the constitution, for the functions that have been devolved, then the government of His Excellency Uhuru Kenyatta recruited for the counties to capacity build them 8,551 health workers from across all the cadres except the doctors. That was in 2020. And you know, sometimes people think that they were employed for COVID. There are actually two sets of contracts. The universal health coverage staff were not employed for COVID.
Yeah.
They were employed before COVID when we were piloting the universal health coverage. But then coincidentally, COVID came in and that was their first duty, to fight COVID. Some of them are still suffering the sequel or the long-term complication of COVID until now.
Yes.
But then we also had the COVID tailored contracts. They were called CHAP, COVID-19 Health Emergency Response Program. And they are still there. It's another team. I think their contract is also coming to an end. So when these people were employed, because the government needed numbers,
Yes.
but they didn't have the money. So there was an agreement. Can we give these people stipends for a shorter time, you know, like they did to the intern teachers with the JSS? And then after some time, within the 3 years contract we are giving them, we look for budget and we can be able to absorb them into permanent and pensionable, because clearly talking, it is discriminatory.
Yes.
As per our constitution, Article 27, as per the employment laws, that you can have somebody who is qualified the same way as I do, doing the same job that I do, but then is paid less than 50% of what I earn. Because that is what that's what happens with them. So the first 3 years ended. And you know what? The government said, oh, we are not ready. We had not budgeted. They went to Naivasha in a summit and said, we are going to extend. So when that was taken to the Public Service Commission, and I must thank the Public Service Commission for the independence, they said, no, we cannot continue having these terms for another 3 years. They are clearly illegal. Why don't we then just give you 1 year so that you prepare to harmonize their salaries, absorb them into the permanent and pensionable, and give them their graduate?
So just for clarification,
Yes.
we're essentially saying that we kept folks on a stipend
Yes.
for 3 years plus. By the time it was coming to this
Until now,
conversation,
this is the 6th year.
so no, I'm saying at the time of that conversation,
Yes.
where the PSC said, you know what, we can't have people on stipends and they're doing essentially PNP jobs.
Yes.
They're doing PNP jobs,
Yes.
but we're keeping them on a stipend. You
Yes.
have to fix it. So at that time, they said, we're going to give you 1 year to do many things.
Yes.
Find the money, reorganize this structure, put people on PNP, let them be working in proper conditions at
Yes.
that time.
Yes.
Okay, please.
And guess what? After the 1 year, the government was back again. We are not ready.
Okay.
So at that point, we protested. And that is when all of us as the unions, we went on strike. One of the issues was about the UHC. Then we were called to a joint meeting of the two health committees from the National Assembly and the Senate. And then they pleaded with us, can you please allow us that we extend for another 2 years, together with the PSC, so that then we get ready. We look for the budget. And we were like, you have not done that in the last 4 years.
Yeah.
Let me ask a question.
Yes.
This budget that is looked for,
Yes.
And in everything, I think this week, every person who comes from education or whatever, they say they're looking for budget.
Yes.
How come budget is found very easily for certain things, including renovations, but not for healthcare? What is the mystery? And how much are we looking for here, by the way, annually?
I think that is the big question. We are looking at 3.8 billion additional to be able to harmonize their pay. Because what is wrong with these contracts? Number one, we are saying there is discrimination. Our Constitution, Article 27, disallows discrimination. Under the Employment Act, Section 5, it actually defines what discrimination at the workplace is. And it says that if you have two people doing work of equal value, but you remunerate them differently, that is discrimination, and it's illegal. Then you look at the Public Service Commission Act. Go to Section 44. It talks about contracts and who should be on contract. And it says that, number one, for you to be on contract, whatever you are doing must be time-bound. I don't think health, at some point, we are going to say we no longer need health services in this country. Number two, it also says that you can only put them on contract if the person, not the person employing, if the person you're employing does not qualify for P&P terms. If you look at the people who do not qualify for P&P terms, either your age has advanced, such that you cannot be put on a pension, or probably that whatever you're doing, as I was saying, is coming to an end within a certain duration. That is not the case. And that is why we are saying that there is an illegal and irregular contract. And the only way that you can be able to remedy the situation, number one, harmonize their pay. That will end the discrimination. Number two, put them on P&P status as the law requires. And number three, they have a gratuity now for 5 years that has not been paid. The first contract ended, they were not paid. The second contract of 1 year ended, they were not paid. And so that is what we have been asking Parliament. And funny enough, even after being told, please give us 2 years, now we realize that in this budget of 2025-2026, there was no budget, yet this is the last year, and these contracts are ending in April of next year. And that is why we raised the question and asked, hey, but the 2 years are coming to an end. And of course, we knew that the same scenario is going to play again. We are not ready. We don't have the budget.
Okay, Peterson.
Yes.
Now, on 17th of February, you were on a strike, and I remember you getting into a negotiation with the government, which culminated to the end of the strike, which was on March 12th. And some of the issues that were agreed was to fast-track implementation of CBA after the negotiations, and clinical officers to be included in the SHA framework, and to address the delay in implementation of previous CBAs. Now, here we're talking about the budget-making process that is ongoing, and even in the current budget that you're talking about that is yet to go to Parliament, that you do not feature and appear in there. And one would argue, or one would ask, that during this process where Kenyans' views are being sought, why are your views sorted as a union, as clinical workers?
Thank you. And you know how you participate in this budget public participation is through the relevant committees. Then those committees are going now to take up the matter and take it to the budget committee. You are not allowed to go there directly.
Yes.
So we tabled this to the health committee, and I think it was in the media that they tried to advance that case. We can only hope. But now, regarding the UHC, leave alone the return to work agreements. By the way, we don't yet have a CBA. The return to work agreements we have are the ones that providing that we should be able to finalize.
Yes.
So in 2023, I think 18th of October, we were in Kericho. And in a very much popularized event, we signed the Kericho Declaration on Health. Number 10, item number 10 of that was saying that this issue of UHC, within 8 months from 18th of October 2023, we would have absorbed them. We signed as unions. The CS Health signed. The CS Labor signed. The CS Public Service and something signed. And I think Performance signed. And the Council of Governors and the Kenya Health Human Resource Advisory Council. That was the first agreement. When we realized in 2024 it was not happening, we went to Senate and did a petition to the Committee on Labor. And it was considered. And in their recommendation, they gave the ministry and the Council of Governors 6 months to consult and effect the same. That never happened. Then, during the strike of last year, then we were brought all together by the two committees of the House. And there was a resolution that within these 2 years, we must have a budget to be able to absorb them. So, if you are talking about agreements, if you are talking about negotiations, we have documents. And that is why we decided this time round. By the way, today we are doing 98th day of the UHC strike. 8,551 health workers who man our level 2 and level 3 hospitals. And that is why people are not getting services there. So now we said, Bwana, we don't want negotiations. We don't want agreements. Just implement what is there. And we are ready. We have told them that if it means that we are going to July, or if they're saying a supplementary in September, they will stay out until that's a supplementary in September, because they have lied to us 3 times. Really, if they lie to us the 4th time, we will be idiots.
I do not believe you would be idiots in any standard shape or form. My question is, and this is for the public, what is the net effect of these 8,500 workers not being there, either by not being absorbed or by this strike actually continuing? What is the actual impact?
Thank you. You know, the 8,551 manning our level 2 and level 3s, juxtapose that with the policy of the Social Health Authority, that you cannot get to level 4 before passing through level 2 or level 3. So what is happening is that, and you know, the uptake of the private facilities down there on SHA has been slow. Either because SHA is not doing enough, or the facilities do not want, because of some of the issues about SHA and outpatient. By the way, SHA is not working for outpatient. It's only working for inpatient. So,
you need to say, so SHA is the authority. There is Chief and Taifa Care.
Yes.
Which one is which?
You know, SHA Chief, SHA is the board. It makes decisions for Chief.
Yes.
So the decisions come from SHA.
Okay.
So it's the head. It thinks for the body that is Chief. Yes.
Chief is the fund.
And
the fund is operated by SHA, essentially.
Yeah, and Taifa Care.
Clarity for people.
Actually, the insurance is SHE. Social Health Insurance.
Yes.
The board is SHA, Social Health Authority. Under the SHE, you have the refunds. You have the Chief Social Health Insurance Fund that you contribute into.
Yes.
But you can only access from level 4.
From level 4.
Okay.
Then you have Primary Health Care Fund that the budget is allocated for you.
Government is the one that
government allocates money.
Yeah.
And that is why the outpatient services will be very limited, because they allocate kidogo.
Yes.
And then we still have the emergency, critical and chronic illness
is the third one.
Care fund. That also comes from the budget. And that is why when you go to the ICU, you'll be told you have to copay. We are only going to pay for the beds, pay for the rest. But anyway, we'll get to that discussion. What I'm trying to say is that now that Kenyans are supposed to first go to level 2 or level 3, and these people are not there, and a good number of the private facilities down there, level 2 and level 3, do not have the Social Health Authority. Kenyans are having to go back into their pockets. You first go to a level 2 that is private or level 3, so that they can refer you to level 4 that is public, so that you can be able to access services.
Wow.
The net effect is we are subjecting Kenyans to the catastrophic financial challenges that the UHC was supposed to address. And number 2, we are also denying them access that they should be getting. So simply saying, we are off the road of achievement of the UHC. And the one on Vision 2030, I don't think we even got to the road. We are somewhere in the bush trying to navigate where the road is.
Okay, I'd like to take a break at this point because we're looking at, we built an explanation around what has been happening over time. And from what you're saying is essentially they've lied to us 3 times. If we go back and take the lies for the 4th time, that we would be the ones that folks are asking the question that what is actually wrong with you?
Yes.
That don't you see how this has been? Very quickly, Peterson, before we go to this break, are clinical officers the stopgap for the shortage of doctors? There are many facilities that you will go into today and there will be somebody who is manning operations. That person is a clinical officer in many cases. Are clinical officers in their own cadre or are they substituting for a doctor?
Thank you. There has been a misconception that clinical officers substitute doctors. Clinical officers complement doctors. And if you want to understand this, look at the UK, look at the Europe, US, who have advanced health system. They actually learned from Kenya and Africa, and they have introduced a similar cadre so many years after they were on the course to achievement of the UHC. But they realized they needed a similar cadre, an analog of clinical officers in their settings, so that they can be able to provide that access. And recently, even UK has actually opened doors. And you are going to see a lot of clinical officers move to the UK. Now, clinical officers from Kenya can actually apply, be licensed, and work in UK as physician associates.
Right.
And US is also opening. So we are not a stopgap measure. We complement all what the other health workers do.
Absolutely.
Yes.
All right. Peterson Wachira is our guest this hour, and we're looking into the plight of clinical officers. 1, CBA unimplemented. 2, another stab at it, unimplemented. 3, another stab at it, unimplemented. Government says, let us reason together for the 4th time. Clinical officers says, no. We'll deal with it another way, and we're trying to find out rather this morning what is the other way that this will actually be dealt with. They're needed. It is not a question about what is needed at medical facilities, health facilities around the country, and the plight of clinical officers is what we are looking at. Patients abandoned is what's in the headlines. 8,571. That's the number of medics that the government hired in 2020 to help contain the COVID-19 pandemic. They've been on the streets for 6 weeks demanding better employment terms. The strike by universal health coverage workers, who include clinical officers, nurses and pharmacists, has disrupted operations in hospitals nationwide. The majority who depend on the public health system are bearing the brunt of the dangerous stalemate as hospitals prematurely discharge patients, because there's nobody to take care of them, essentially. While the situation was already dire, the crisis is now snowballing into a national catastrophe as doctors in various counties have now joined the strike with numerous grievances, including salary delays and punishing schedules because of shortage of personnel. Now, while that happens, expectant mothers cannot access safe delivery services. Children with life-threatening conditions are being turned away. And other patients with chronic diseases are missing critical treatment as the standoff between striking doctors and counties takes a deadly toll. This is the reality of what we are dealing with here. So when we say a no to a CBA, or we say we cannot implement a CBA once, twice, thrice, this is the result. Okay? And it's giving both sides. You employ them, but you don't cater for them. What happens? The lives of people now hang in the balance. What needs to happen in order for this to be taken seriously? One would imagine that you did not shackle the government to sit at a table and say, give us this CBA. They did this of their own free will and understanding. Is it a no money issue? 3.8 billion shillings doesn't seem like what the governments of the day cannot afford, especially when we see this thing of women dying, children, others with chronic diseases. It doesn't seem too much of an amount to put in place for people to come back to work. So what is wrong?
You know, if you look at the budget, the security sector, I think the NIS, or is it the DCI, I think there was an addition of, to the tune of 94 billion or something.
To what now? Security.
To the security sector.
Collectively. So some of that falls in different sectors under the office of the president and,
if you look at the presidency, there was an addition. There was an addition of several billions. I can't remember how much, but I think more than 12 billion. Why is it that we cannot get 3.8 billion? Then the other question is, last year we went for the longest strike ever for clinic officers. That was 124 days. And that culminated into a return to work agreement.
Yes.
Among the things that we agreed on, one was we are going to sign a CBA.
Yeah.
For the national government, we have negotiated, we have completed. The Treasury has given a nod for whatever needs to be enhanced. It is lying at SRC for the past, I think, around almost 6 months, from December. Then the counties, we stopped somewhere because they were waiting for the Treasury to give them a nod, which they have done, and they have refused to come back to the table. The issue of the UHC was still there. And not only UHC, we have other contracts. And I think it's good that Kenyans know the biggest threat to health service delivery and to the universal health coverage in this country is casualization of labor in the health sector.
Yes.
A doctor goes for internship, is paid to 206,000. Then after, they are given a contract under counties of 100,000. A clinic officer goes for internship and is paid 110,000. They come out, they are given a contract, if it's UHC of 50,000, there are some counties who are even paying them 35,000. We have so many contracts. We have one called Global Fund, and I think we must talk about this. These are people who were employed in 2009 by the Ministry of Health, funded by the Global Fund. They have been taking care of HIV and TB. In their contracts and in the contract between the Global Fund and the ministry, they had indicated that one of the things they were to do, that is the government, is that at the end of the contract, they were supposed to absorb them. After serving this country for, how many years are those? 209?
That is 16 years.
16 years. When the Global Fund now handed them over, the Ministry of Health said, we will only absorb the ones who are working under the national government, and those working under the counties were left to the counties. And there is a directive of the Public Service Commission that they should be absorbed as per the agreement between them and the Global Fund. As we are talking currently, for 11 months, they have been working and they have not been paid a dime.
Hey?
Last year in April, a clinic officer, a young lady, took her life and that of her daughter because of depression, because of that confusion and not being paid, of course.
Yeah.
And I remember we aired that, and that was one of the reasons we actually went on strike last year, to try and address this. Up to date, yesterday we were with them with the Senate committee, and some things, you really don't know whether to say it's unfortunate or that is why sometimes as Kenyans we have to get angry. Then you look at the counties, they have some contracts they call casual contracts. Something that is even undefined, because it's either it's casual or contracted. You cannot have casual contracts.
Yes.
They are paying them. You find nurses being paid even up to 20,000 under the counties. You find others under the counties now called county contract and paid like UHC. Another one is on PNP.
Allow me to understand something.
Yes.
That when we say being paid, right, the assumption is that there's a job that's being done.
Yes.
And we had the folks from the Nurses Council here a couple of weeks ago, and I asked this question, that what does your day job look like? You're on a shift for between 24 and 36 hours, right? You don't do 8 to 5. But they're saying that in a week, certain hours must have been covered. There is no medical facility shift that lasts less than 24 hours. Am I correct?
True.
Okay. So between 24 and 36 hours, you're at work. You're doing everything, whether it's seeing patients, whether it is doing procedures, all of that, between 24 and 36 hours. And you have maybe a day or so off in the week, but so long as the hours have been covered. So you're putting somebody under a casual contract. The oxymoron of it is still, there. But you're putting somebody under that. They are working the same number of hours, if not more, than somebody who is on a P&P. So there is no difference between the work somebody here is doing on a casual contract and the work that somebody here is doing on a PEP. Or is there? Is there a difference in the job that they're administering?
No.
No difference.
They actually do more.
Okay.
Because what necessitates that contract is that there was shortage.
Because the assumption, or rather the perception, is that because somebody's put on a casual contract, that maybe they're coming in to fill for a couple of hours, every day, and then they go back. But they're doing a full-time job on this contract. All right. Now, what beyond the money would it take to ensure, and we're not saying hire new ones, we're saying the ones that are currently working, to improve their situation beyond the money would it take for them to be in a place where they say, okay, fine, let's just do the work? What would it take? Because from what I understand, the CBA is not all monetary elements.
Yes. Thank you. And we cannot first go beyond the money.
Okay.
Because money will be everything here. And I think to contextualize this, that is why I was saying that the contracts will be the biggest challenge to achievement of UHC. Why? UHC is about quality. And you marry it with the Vision 2030 that we want to be a specialized and subspecialized health system that attracts people from across the globe. But then, when you give people short-term contracts and you pay them a meager salary, number one, under the short-term contract, you cannot take them back to specialize.
Yes.
And number two, even after the contract, they cannot go back and specialize because they were barely surviving with what we are paying them. They cannot pay for themselves. And our specialization courses are very, very expensive. And so in future, the gynecologist, the urologist, and the other specialists that you see around, you may have to cross the borders to get one if this takes root. This is one of the reasons as to why we are coming out forcefully and trying to address it. Sometimes Kenyans may think that we are looking after our welfare. But we can look at the future, we can look at what's happening, and we can actually tell that we are actually backtracking. But coming back now to these agreements, it is beyond money, because we're also talking about what is the working environment.
Sure.
When you are working in an environment where you don't have the equipment, when you're working in an environment where you don't have the essential drugs, then, it becomes traumatizing to you. There is nothing that affects us mentally as knowing that I lost a patient that I could have helped just because I was lacking 1, 2, 3. I remember during my internship period, a patient died because there was a delay in refilling oxygen, and people had complained. Do you know we had to go on a strike until we could get oxygen back? Because we couldn't take it. Yes.
Okay.
I will not say which hospital, but during my internship, we actually had to go on a go-slow for a day. All of us as health workers, it is a mission hospital, for them to be able to get oxygen wherever they could, because we were losing patients.
Now, Peterson, when you talk about healthcare and the importance of the staff that work in these hospitals, one would just, people would look at health workers as people who are just seated there. We walk in, we see them, and we really never get to think the role that healthcare workers do play. But there is the aspect of the cabinet secretary for healthcare and the importance of him being the champion in making sure that healthcare in the country works, because he is the linkage between healthcare workers and the leadership, say the government, right? And in all these, even today, as we talk about healthcare workers being on strike, we're talking about almost how many days now? 98? 98 days on strike. And the cabinet secretary is seemingly quiet on a situation that is dire for the country, because we're talking about millions and millions of Kenyans who require these services. Past 2 weeks I've been in a hospital because I had a patient, and you walk in and the people who receive you, take care of your patient, are healthcare workers, people who are integral in this system. Why doesn't the cabinet secretary or the government take this as a serious matter that it is?
Thank you. And I think
Why is the disconnect?
I agree. There is a lot of disconnect, and maybe to even compound that, I think we came out and we gave a notice as the unions that if they read that budget and there won't be money for transition of the UHC, they will basically be calling us out on a strike, and we are going to have a joint national strike. Not that we like strikes, but that we really want to help Kenya to get back on track. So the disconnect, and the CS has been talking, but the talking has not been helping. Because the predecessors, the CSs who came before CS Aden Duale, did not do their job. They did not budget for this. And I think we must say the truth. And CS Duale probably came late in the day, and we have sat with him. He seemingly is trying to do what he can be able to do to salvage the situation. But I think now the honors are on the parliament, because by the time he was coming in, I think the budget had already moved to parliament. And that is why every Tuesday or Wednesday you get the UHC camping in parliament, so that whenever they are considering budget, they remember there is somebody who is shouting out there until they can be able to get it correct. But you're asking about the disconnect. The disconnect is that our government, our administration has not understood that health is central to any social and economic development of any society. They do not see health as an investment. They see health as a liability. And until we can be able to look at health as an investment, where then, if we are able to alleviate the suffering, if we are able to prevent the disease in the first place, then the money that we are taking to India, the billions we are taking to India, is going to remain here and spur the economy. If we have people coming from outside for medical tourism, they're going to bring in the dollars we are looking for. And that is going to spur the economy. I think that is the understanding that we are lacking. And that is why I keep on saying, that is why we never got it right with SHA. And because the reason for me I say we never got it right with SHA, I know people will argue otherwise. SHA and the universal health coverage is about prevention of disease. It's not about curing the disease.
It's not curative.
But if you look at the Social Health Authority, the more you move towards prevention, the lesser you get it being funded.
Well, but you just look at the three funds. Look at the three funds that we're talking about. At the first level, where we are saying that a lot of the preventative work takes place, is where the least of the money is.
Yes.
Where a lot of the curative work happens is where most of the money is, which is where Kenyans are contributing.
Yes.
And then at the very end stage is where a lot of the curative or chronic diseases are happening. Again, is where money will come in from external partners as well.
Yes.
Whereby we should see the bulk of the money at the first tier. Because that's where you're going for your screenings, that's where you're going for your checks, that's where you're doing all these things.
Actually, SHA is a business model. SHA is designed to send patients up the ladder of the levels.
As opposed to making sure that down
the hospitals are going to earn more. And in this way, that under the primary health care, where we are supposed to prevent the disease, we underfund. So that then you don't get the services, we don't prevent the disease. When you get ill, we also tell you, the money you are contributing, you cannot use it here. You cannot prevent your disease. You'll only use it when you are curing. So, you have to wait. If you don't have the money, you wait until then you are sicker. You get to level 4 so that we can be able to treat you. And even look at it, the inpatient. Actually, I can assure you, every hospital, even the small ones, you'll see them expanding to get inpatients. Because there is better money when you have an inpatient. But on the outpatient, you get less. Actually, you are not doing any business if you only have an outpatient facility. So what are they telling us? They are telling us they don't want primary health care. They don't want to prevent disease.
Peterson, we have to ask a question, because here we are, and I'm just writing down this list, that currently this is just me.
Yes.
I know 7 people, 7 right now, who are in India on treatment.
Yeah.
One is going on Sunday. So
Yes.
that by Monday it will be 8 people. How many other people do we know who are also in that same thing? And what we're essentially saying is that these things can be sorted out so that this treatment is actually facilitated here in the country,
Yes.
and that the medical workers who are they are in abundance. Where we say there's a shortage, it's a shortage because you have not
it's an artificial
employed. It's an
shortage.
artificial shortage,
Yeah.
because they exist. How many people come out of our medical institutions every year? But we don't absorb them because, one, we've not prioritized healthcare. Number 2, we've not put the money where it's supposed to be in terms of hiring them and then looking at things like preventative care, which, by the way, if you have a conversation with the folks at the ministry, that is what the priority is, to leave curative and go towards preventative. So we've been having conversations. We've had CBAs. There have been promises made and unkept. And we're going into the 4th round of the same. It is unprecedented that 6 weeks into a care program, that the workers in the care program are on the streets. That's the reality that we are working with. And we can say that 3.8 billion shillings will solve the problem. And that's why the money question came in. Is it not more than money? Because if I don't have the will, or if I don't have the desire to prioritize this thing, give me 100 billion shillings and I'll do anything with it, but it has to be backed by the will. Do we actually have those who are practicing in the health sector willing to make health a priority? Do we?
Of course, for us in the health sector,
The people who make the decisions.
of course, the people making the decisions and their politicians, they see health as a liability. And that is why health is not actually being funded. And I think let me even lay more context to this. You know, in future, Kenya will be an internship field. Kajiado, I think in 2024, lost 100 and something nurses to UK. And you know what is happening is that the UK and the US and the Australia, they're actually taking our experienced nurses. So when you're applying, actually they want your years of experience. And the more the years of experience, the better for you. So very soon, and especially when we have the exodus of now nurses and now clinic officers are getting in there, people will be doing their internship. They can even lurk around those hospitals for 3, 4, 5 years to gain the necessary experience, and then move and take the experience elsewhere, just because we are unable to take care of the welfare of our health workers.
But you know, I've been listening very carefully, and I think there's a big disconnect in a lot of our policy statements in this country versus our political actions around them.
Yes.
Because if you look at the policies and everything that even Parliament itself will say, or even the government itself will say, you see very cogent arguments and directional arguments that make sense. But when it comes to the implementation and the political decision to do so, we are stuck. Is that really the case that we are seeing in this country?
Very true. I think you have analyzed that very clearly and explicitly, that we talk very big.
Yes.
Look at the plan, my friend. The plan is beautiful. 20,000 healthcare workers within 100 days. We are still waiting for the 100 days to end because we have not seen the 20,000. Even the 8,551, we are unable to take care of them. There was the issue of taking people back to school. We are going to ensure the CBAs are done. But when it comes to the action, as you're saying, then we have better places to take our money.
It's a big issue. And unfortunately, this is one of those conversations that we leave hanging. We don't have an end to this conversation because it's one that must continue. That we cannot be dealing with lack of implementation as the problem when it comes to the healthcare of this country. Healthcare of those who will seek it, and also the healthcare of those who will administer it. So we can't stop, Peterson. We need to keep talking about it. We need to keep bringing these issues to the fore, and we need to keep this discourse alive. Something has got to give at some point.
True.
And we can't tire. And we want to thank you so much for being here with us this morning. Ours is to make sure that we keep
Maybe
these
my
issues
last
front and
statement.
center. Yes.
My last statement would be to His Excellency President William Samoei Ruto, because we sat with him before he came in. And I want to tell him that his legacy will be on health. His legacy that is going to be remembered long after will be on healthcare. So he really needs to define what his legacy will be about. And for now, that is still a bit on the grey.
Right.
He really needs to take it on the green.
And it needs to be clear.
Yes.
Peterson is the chairman of the Kenya National Union of Clinical Officers. Kuko, thank you so much for being here. Good morning.
This is the Situation Room, the only way to start your day.